I'm Amy Mack, Program Manager for the California Opioid Safety Network at the Center for Health Leadership and Practice, a program of the Public Health Institute. You are about to watch a webinar that has been condensed from its original format to provide specific content regarding strategies for distributing naloxone. During the webinar, we will cover trends, existing strategies, and lessons from the field. The subject matter expert for this webinar is Dr. Matt Willis, our clinical lead for the California Opioid Safety Network. Let's get started.
The epidemic has really continued to accelerate nationally, and the main contributor to the epidemic is synthetic opioids, especially fentanyl. The situation has changed now, and it's more volatile, and the denominator of people who may be at risk of overdose has increased based on the new supply side of having fentanyl being sent from China and Mexico, with the younger age cohort using opioids, and the strategy of widespread distribution of naloxone to be, there where and when it's needed in the setting of an overdose has become even more important. There are now estimated 72,000 opioid-related deaths in 2017, with a really stark graphic here that shows that synthetic opioids are really the contributor, almost the sole contributor to that acceleration of overdose deaths, fentanyl being the dominant agent there. We want to be prepared for the eventuality that fentanyl may hit California the way it's been hitting other areas, and having naloxone widely available in our communities will be an important way to save lives. And we've got a plan that we are sharing with you all from Marin County, which is a relatively long plan. It's about 19 pages. It's a Word document. You can feel free to extract any elements of it they would want for their own plans, but the key elements are why, what, who, when, and how. So what is the rationale for the distribution? What are the basics of naloxone? Who, naming the partners and the sectors that are included in the plan. When, importantly, timing with SMART goals. So specifically, when do you expect to have naloxone distributed to which partners? And then the how, which policies, forms, and relevant legislation are necessary. And those are the sort of the core elements of a naloxone distribution plan that you can find in the version that we'll be sharing from our coalition, and there are other versions as well. If you look within our plan, each sector has a specific goal around naloxone, and this is how we address the goal of getting naloxone into our first responders and police, which was by March 2018, we wanted all units in at least one police jurisdiction in Marin to carry naloxone with officers trained in its use. We wrote this plan prior to having really reached out and engaged our police, and didn't know what the appetite would be or how much success we would have. The current status actually is that we met and exceeded that goal. In fact, all units in all 12 police jurisdictions in Marin County, because there are 12 cities and towns, are carrying naloxone with officers trained in its use. And here's the process we went to distribute. We started with a letter to the police chiefs that was written by the health officer and the chief of addiction services, and it came from Department of Health and Human Services and RX Safe Marin Coalition. Followed up with phone calls to all the police chiefs. Those who are most willing, there was 2 who actually invited us initially to come and train their staff. The training needed to be an EMS certified training, so we sent this to our EMS agency. They certified the training. Once we were offering that training, we had willing precincts sign an agreement to receive naloxone from the county. We had county supply of naloxone from California Department of Public Health in the grant that all of us have been eligible for. We provided the kits either by bringing them to them directly or having them come in to our offices to sign an agreement, and provided the kits for each squad car. We're maintaining contact with them for resupply when they use the naloxone, and we're tracking reversals. We had 2 press releases associated with this. The first was around when the first officers started carrying naloxone, and the second one was when the first officers actually started using naloxone. This is the training, which will be available on the website. This is the EMS certified naloxone training for law enforcement. We borrowed this from Sierra Sacramento EMS agency, and it has been vetted by that agency and others. So if you're looking for an EMS certified training, this will offer that. This is the example of the press release. This is Dr. Jeff DeVito, our Chief of Addiction Services, holding up a Narcan kit, and it's opioids in Marin, Santa Fe Police Department to carry overdose prevention drug Naloxone. And the quote from the captain is, "Naloxone is a great tool for our officers in the field. Police are often first at the scene, and being equipped with Naloxone could save a person's life." So the police themselves were endorsing this as an important public health intervention, and we were able to celebrate that in a press release. This is our process for schools. Another sector that we built into our Naloxone distribution plan was getting into the schools. We had set a goal by March 2018 to have one Naloxone kit available in 5 high schools in Marin County with a nurse and at least one other person trained in administration. That we had less success relative to the police effort. We only have Naloxone in 2 of our high schools now and had to go back to the County Office of Education to do a more robust appeal at the county level for them to actually adopt a policy through the board of the Office of Education that would apply to all middle and high schools. Instead of taking it on a school-to-school level, we actually decided we needed to go based on the school board's decision to take it to the central school administration. So we started with a letter to the superintendent of schools. We made a presentation to the school board, got on the agenda at a regular monthly meeting. We had a presentation and training to school nurses. The school nurses meet on a monthly basis and added Naloxone training, train the trainer training to that meeting. We developed a protocol with the Office of Education. There's an agreement to receive Naloxone from the county similar to the agreement with police. We're using the county supply from CDPH. We have provided kits to those 2 schools that have already started carrying it. And then we're, again, also maintaining contact, and we'll track reversals as they occur in the school setting. This is a protocol for the administration of Naloxone in schools, referring to the law, and it's something that can be shared. It will be also available as a resource for anyone to use. It's about 4 pages long. And this is the agreement with the schools in terms of actually the form. It's just a 1-page form that a school nurse will sign when she comes to pick up Naloxone from our team, just saying that we are hereby receiving and accepting free Naloxone from the Department of Health and Human Services, and we'll store it and handle it properly, and we'll be trained, et cetera. So these are the steps that we thought were important in successful distribution, which was starting with the most willing partners, doing some education about the value, making sure that we're training them in its use, providing the protocols, providing the product, monitoring use, and celebrating rescues. We've been quite close with our partners at every stage of this process. And these are some of the reversals that we're celebrating. So this is the first time one of our police officers used Naloxone in the field to save a life. There was a press release associated with this. And Officer James Rincor has been actually one of our best champions now in trying to promote Naloxone use more widely, and speaks really compellingly about his experience of reviving this person. And the lower right there is someone from, I think, Humboldt County, a librarian who saved a life, is someone that was found in the stacks of the library having overdosed, and she had been trained in Naloxone use and was able to actually use Naloxone in that setting. So those are Marin County examples, but we're going to hand it over now to Kismet Baldwin from San Joaquin County Opioid Safety Coalition. Kismet is the health officer, a relatively new health officer to San Joaquin County. She was born and raised in Ohio and attended Ohio State University. She trained at Sinai Hospital in Baltimore and went on to complete a neonatology fellowship at UCLA. She then went on to practice in the NICU in New Hampshire, where she saw firsthand the downstream effects of larger public health issues on her patients, including opioids. After a few years of patient care, she decided to change career tracks, hoping to make some waves upstream to impact the health and well-being of the community.
We received our first supply of Naloxone, as did most of the counties in California, through the California Department of Public Health Naloxone distribution grant. We got our Naloxone, and in the meantime, we were in the process of writing the standing orders for Naloxone distribution and completed the standing orders. Our county did require a memorandum of understanding to be written and approved by our county council for any distribution in the county. I don't think every county required that. Then once we had both of those documents and our protocol, we invited the harm reduction group from San Francisco to come in. It was a free session. and anybody from the county was invited to learn a little more about what harm reduction is, number one, what the goals are. Naloxone administration was demonstrated in a couple of different ways, intranasal and through syringe, and train the trainers at that point in time. And we had a pretty good turnout. We kind of picked up steam from there. Recently, we've applied for a grant through Aegis Treatment Centers. They've received a grant or money from the U.S. Department of Health and Human Services to buy naloxone and then distribute it to other agencies or into the community themselves. So we've applied for a grant through them, and they are going to provide us with some more kits of naloxone so that we can get them out into the community. So the first thing we did is we did community outreach, and who are our partners going to be? Who do we want to get this naloxone out to so they can get it, distribute it into the community or save a life? The top places we thought of were county behavioral health services, because they do have treatment centers. And if you just look to the right, I'm kind of going to go through who we were talking to and what some of their reasons or for not taking the naloxone kits originally were. And we were a little surprised by some of the answers. We just thought everyone was going to want it, and we realized fairly quickly that not everyone agreed. So when we spoke to behavioral health services, some of their social workers that work with people in substance abuse treatment plans, they felt like giving out naloxone could encourage their clients to continue using. That we heard that many times. They weren't sure about safe storage. They don't have necessarily room temperature at all times, and so they weren't comfortable keeping the Narcan in their centers, some of their buildings. We talked to people at the homeless shelters, and they didn't feel like it was a safe area to keep it. They've got rotating staff. They didn't really have anywhere to kind of lock it away. They also mentioned their concern for people continuing to use or use more often if they have access to naloxone. Correctional health. They were a little more interested, but they did need to kind of figure out who and how to distribute it within the county jail system. So they were our most interested willing partner at first. And then we went around and spoke to some local pharmacies. They just really didn't feel comfortable being a point of dispensing. There is law out there now that anybody can walk in and purchase naloxone over the counter for a fee. We spoke to the University of the Pacific School of Pharmacy. One of their professors is very involved in public health issues. He was interested, but again, he had to check with the school risk management to see if this was even feasible. And then we, of course, spoke to law enforcement, and we didn't start with a letter. We're concerned about liability for law enforcement, giving a medication, and what if it was given to the wrong person and it didn't do anything, or they really weren't comfortable. And then another statement was, in our county, it only takes less than 5 minutes in most places for EMS to arrive, and they're usually there before our law enforcement, so why do they need to carry it? It should be EMS who has it. And they've already saved the person at that point in time from an overdose, so they didn't see the need of law enforcement actually carrying it. So going back to our more willing partners, correctional health, they jumped on board relatively quickly, and we met with their chief medical officer for correctional health and their deputy director, and kind of discussed the standing order, the MOU. We talked about how to train their staff. They could come to public health. We would do a training on how to administer naloxone, and then they could then go and train inmates, and even more importantly, the inmates' families and friends to administer naloxone also at the time of release. So they developed a plan along with us. They already have an intake screening process where they're asking inmates coming in, have you ever used an opioid? Have you ever, used heroin? And have you ever had any kind of withdrawal or overdose? So they're already doing that, so they would flag those people, and then at the time that they were released, they would go through the training with that person and their family and friends and give them a kit, a naloxone kit, when they were released. And they took about 200 of our kits for that. Our second big success was the University of the Pacific School of Pharmacy. One of their pharmacy professors is very forward-thinking in public health. We, again, discussed the MOU, the standing orders, and he took it to his risk management in the university. They approved it, and once that was approved, we discussed how to train their students, and actually it was kind of nice training the pharmacy students because they pretty much know how to deliver the medication. They plan to hand it out at their school pharmacy if someone wants it, and it'll be for free since it's coming from us. And they also do, like I said, a lot of community events, especially starting in October, so they plan on handing it out during their community events also. We really wanted to get some more people in the county involved, so we contacted our local newspaper regarding our supply of naloxone, and most people didn't know we had it. And we did an article with one of their reporters where we discussed, where we obtained our supply of naloxone, who the population we were targeting, why we thought it was worthwhile to distribute in the community, stating some facts about opioid deaths in our community. And as part of that interview, she actually wanted me to demonstrate how easy it is to administer naloxone. So she did a quick video of me going through as a tutorial on how to administer naloxone, and so that got put into our local paper along with the video if it was online. Things really took off from there. We were excited. Some TV news stations contacted us for interviews. From there, we really started to pick up speed. Law enforcement is now requesting naloxone from us, our sheriffs or our county, a couple of the cities in our city police forces in our county. So we're excited about that. The school district also, Stockton Unified, their head of nursing really wants to learn more about it and try to get it into some of the schools in the county. We've also started doing direct distribution by our staff. So from our extra supply from Aegis, when we go out to homeless shelters and administer Hep A vaccines and things like that, we offer naloxone to the people that we're giving the vaccines to. It's picking up steam. We hit some barriers and some roadblocks in the beginning, but I think it's really going to get out into the community much more widespread in the near future. My contact information is up here on the screen, and Ziana Blackwell Rodriguez, she's one of our senior deputy directors, and she's been heading the naloxone distribution program also. So both of us, if you have any questions, any concerns, any help that you want to give, feel free to contact us so we can send you what we have. I think I provided a couple of our MOUs and our standing order and our naloxone protocol to the organizers of this meeting, so they certainly have those to send to people as examples if you need it.
Thank you, Dr. Baldwin. It's inspiring to see how much you've accomplished in those few months you've been there. I'm just going to offer now some of the specific resources that may help you. This is relevant California legislation. So the first of these, AB 472, is the Good Samaritan aspect of this, basically saying that if someone witnesses someone having an overdose event, there's no liability for that individual reaching out to help that person. The next one is the Civil Code 1714, which allows prescribers to prescribe naloxone to family members, friends, or other persons in a position to assist the person, which is sort of an interesting nuance of this, which is obviously as physicians, when we're prescribing medications, we're normally prescribing to the individual that is our patient. In this case, you can actually prescribe to someone who is close to that patient, a family member. And that needed to be sort of specified in the Civil Code, and that's the code. AB 1535, this is the law that has gotten a lot more play recently, where pharmacists can furnish naloxone in accordance with standardized procedures and protocols. So this is some of the efforts that we're trying to work now with our pharmacies at the local level and across the state to make sure they're actually taking advantage of this law that now allows them to furnish naloxone. The word furnish is an important piece to this. They are not prescribing naloxone, and they are not dispensing it. Dispensing is what they do when they have a prescription for, a physician writes a prescription, they dispense it. They're also not prescribing it themselves. They're furnishing naloxone, which is a technicality that I've learned matters to the pharmacists. And then AB 1748, a school district, this is for schools. So any of the efforts that you're trying to do with schools, you can point to this particular piece of legislation that describes exactly how and why schools should be carrying it and dispensing naloxone or administering naloxone on campus. So this is a project here in Marin County where we're actually tracking all naloxone use, all opioid overdoses in our 911 system. And it allows us to actually evaluate the impact of our naloxone distribution plan. And it's called Preventing the Next Opioid Overdose. And this is called Live Stories. It's a data sharing platform that we've started using more. And this was what I thought was important to share, which is what this shows in this lower left box here is that in 2015, there were no occasions in Marin County in which the EMS had arrived on an opioid overdose scene where naloxone had already been administered by a bystander. So really the only naloxone that was being administered across the county was by EMS. We started ramping up in 2016, trying to get it further into the community. And in 2017, 17 of our opioid overdoses, when the ambulance arrived, naloxone had already been administered by someone who was present. And that is a sign that we are being effective in terms of getting naloxone more widely distributed. Ideally, if naloxone was more widely available, there would be more and more occasions on which, if someone was actually overdosing, we wouldn't have to wait for the ambulance to arrive. And then we've been able to track who is actually administering the naloxone when it's administered in the field. And it's family, friends, police, prison staff, and rehab and nursing staff. And this red here is bystanders, friends, and then we also have police here. One important point of clarification is that Medi-Cal does cover intranasal naloxone. For anyone who's covered with Medi-Cal should be able to receive that without having to pay. The process, though, because it's a carve-out through DCHS, it requires the pharmacist to know that they have to bill for it differently. And that's one of the barriers we're seeing is the pharmacies themselves are not always aware of the process of billing DHCS for the Narcan. It's billed differently than other medications are. If that ends up being a barrier within your own community, one of the things we've done at the local level is just to offer a kind of a worksheet for the pharmacies to sort of understand how you would actually bill for Narcan for a Medi-Cal patient.
Thank you for watching this video. Please visit our website, CaliforniaOpioidSafetyNetwork.org, to access tools and resources, information on funding opportunities, and more videos in this learning series on opioid safety strategies and coalition development.